Welcome back to my channel, Gynae Wizard. So, as a part of World Contraception Day, which was celebrated yesterday, I would like to also create awareness about something called as intrauterine contraceptive devices. So, today our snapshot number 6 will be about IUCD. So, what do we want to know about intrauterine contraceptive devices? So these are the devices which are placed inside the uterus and they act as a method of contraception, and they are one of the form of LARC. So what do we mean by LARC? It is long acting reversible contraception. So what are the indications of intrauterine contraceptive devices? So whenever a woman wants to space her pregnancies for 2 to 3 years or 5 years, or if she wants a pregnancy free period for more than 5 years, that to up to 10 years, we can use intrauterine contraceptive devices. And what is the main advantage of it? That it can be inserted immediately after delivery. So it could either be a vaginal delivery or cesarean section. We can use a IUCD, and the fertility return is very immediate. That's return fertility is just immediate in the next cycle. So if she's inserted a copper T and we remove a copper T this cycle, she can resumption of fertility occurs immediately in the next following cycle, and she can conceive, and it does not require any other supervision, or does not require any other monitoring during the time of placement, and also it does not impair any sexual activity, so it does not interfere with the sexual activity, and it can be safely used breastfeeding mothers. So that's why this IUCD is the most preferred form of contraceptive device. And what is the mechanism of action? So what is the mechanism? So mainly the intrauterine contraceptive devices create a foreign body reaction. So they have a foreign body reaction inside the endometrium. So it could either be a biochemical or an inflammatory reaction inside the endometrium, which results in the in blockage, or it can result in a areceptive environment for implantation. So implantation will not be occurring because of this foreign body reaction. And when it comes to intrauterine contraceptive devices, we have three generations of intrauterine contraceptive devices. So the first generation are nothing but the inert devices, so which were first used and which do not release any substances from it. So they are placed inside the uterus and they have a foreign body reaction, and they do not allow implantation to occur. So it impairs the implantation to occur. Next, after generations passed, there was introduction of copper T devices. So these devices are wound with a copper wire, and this releases some amount of copper daily, and it can be safely kept inside the uterus for about 2 to 3 years or 5 years or 10 years based on the amount of surface area of copper on that particular device. So this copper also forms the inflammatory reaction, and this also is gametotoxic. So it directly be toxic to the sperms. So it can directly kill the sperms, or it makes the endometrium unfavorable for implantation. So that's about copper T devices. And the last generation, that is the best out of it, is the hormonal devices. So we have the progesterone devices, that is LNG IUS, which is the commonly used progesterone intrauterine system, so which is inserted inside the uterus, and it also makes the endometrium unfavorable because it also has an antimitotic action over the endometrium. It causes thinning of the endometrium, and it will impair implantation. And also progesterone, which is released, will thicken cervical mucus, and cervical mucus thickening will prevent the ascent of sperms into the uterus. So these are the more important mechanism of actions when it comes to the hormonal devices. And based on the amount of progesterone which is present in these devices, we have different types of progestocert, LNG-IUS, and there are other newer forms like Skyla. So today we will be discussing about all these forms of IUCDs. So this is the one slide snapshot of intrauterine contraceptive devices. So these two belong to the first generation IUCDs. So they are inert devices. So this Lippy's loop, which was also formerly called as just loop or safety oil when in coil, which introduced inside the uterus, they just cause a reaction in the uterus and they impair implantation. So these are the first generation intrauterine contraceptive devices. Then came the copper T devices. So this copper T 200B, so 200 suggests that there is 200 mm cube of surface area of copper which is woven on the vertical limb, and this can be safely used for a period of 4 years. And then coming to copper T 380A, which is recommended by the National Family Planning Initiative, and it is also recommended by the National Health Mission. So the horizontal arm contains 33 and 33 mm cube of copper, and the vertical arm contains 314 mm cube, and this is also has a silver core and it can be safely used for 10 years. So it's like a longest active copper device. Next coming to copper 20. See, so this contains 220 mm cube of copper and it can be safely used for 3 years. And next the Nova T, which is a recently one, and it also has a silver core and it has 200 mm cube of copper and it can be used safely for 5 years. Next coming to the copper, so it is 26 mm and 35.9 mm length, and this is polypropylene impregnated with barium sulfate, so it's radio opaque, and this also has 200 mm cube of copper surface area. For about 3 years it can be used. And then a gynae fix or a copper fix, which is just inserted into the myometrium with the help of an inserter, and has 6 beads accounting to 330 mm cube of monofilament polypropylene thread, and this can also be used for 3 years. And then you have copper T 380 slimline, and then a recent one is a multi 375. So it is already in the position is in the shape of the uterus, so we need not load this multi load 375, and this 375 can also be safely used for a period of 5 years. So all these are second generation devices, and the last generation devices, that is the third generation devices, are the hormone secreting intrauterine contraceptive devices. So in this progesterone contains 60, also is a small one when compared to when compared to uh, this LNG-IUS, and it contains 38 mg of progesterone, that is the levonorgestrel, and 65 microgram per day is released, and this can be safely used for a period of 2 years. Whereas the LNG-IUS, which is famously come by a brand name called as Mirena, it can be used for a period of 5 to 7 years, and it contains 52 mg of levonorgestrel with 20 microgram, which is released daily per day. So this is about a Mirena, or also called as LNG-IUS, and this Mirena contains a polyethylene film which contributes to the levonorgestrel, which is instilled into the polyethylene frame, and it has a reservoir cylinder, and daily 20 microgram of LNG will be diffused from the cylinder, and it will go direct on the endometrium, and it causes thinning of the endometrium and helps that it acts both as a contraceptive device, and also it is the first line of therapy for abnormal uterine bleeding whenever there is no distortion of the uterine cavity. So these are the various generations of IUCDs which are available in the market. Coming to the failure rate, and also called as the Pearl index. So the Pearl index of copper T devices is usually around 0.3 to 0.5, whereas the LNG IUS has a lower Pearl index of 0.2 to 0.3 per 100 woman year. And next, coming to the timing of insertion. So when do you want to insert a intrauterine contraceptive device? So it can be inserted immediately after the delivery. So with 48 hours of delivery, or it can be immediately inserted after third stage of labor. So that is called as post-placental intrauterine contraceptive device. So postpartum, in that, one is less than 48 hours and one is just immediately after the third stage of labor. We use and insert the copper T. So that is called as a post-placental copper T after third stage of labor, and it can also be insert intracesarean. So after delivery of placenta, intracesarean, we can insert a copper T. So post-placental, we have something called as a Kelly's forceps, and we hold the copper T and go in the line of the wall of the uterus and place the copper T in the uterus. So the insertion is called as post-placental in after the third stage of labor, and after the delivery of the placenta in the cesarean section, we can directly insert the forceps either with a sponge holding forceps or with your uh, hand only. So this is called as a postpartum intrauterine contraceptive device. And then we have something called as a interval insertion. So whenever she is menstruating, so immediately after the fifth day or sixth day when her bleeding stops, so we can insert a copper T or an LNG. So the advantage of this one is that clearly we have ruled out pregnancy in her because she has just got her menses. And the second thing is because the os will be slightly open in the immediate postmenstrual phase, it is easy for insertion, and the pain and discomfort during insertion can be minimized. So these are benefits when inserted immediately after the stoppage of menstruation within 7 days of the LMP. So that is called as interval insertion. And the second thing is we can insert this immediately after the abortion also. So especially if the abortion is taking place within 12 weeks, so either a medical or a surgical abortion within 12 weeks, immediately we can insert. If it is after 12 weeks, it is better for us to give a gap of 4 to 6 weeks and then insert, because the chances of expulsion will be high in a second trimester abortion. So these are the different timings where a property can be inserted or an IUS can be inserted. So now we have understood the timing of insertion. So we have to do a detailed counseling about the benefits, risks of all these devices, and we have to take an informed consent. And after this, we have to rule out if she has any other comorbidities, and that's when your MEC criteria comes into existence. So what is this medical eligibility criteria and what are the different categories for property? So Cat 1, Cat 2, Cat 3 and Cat 4. So which I've already mentioned in my previous video. Cat 4 are absolute contraindications. So when is the absolute contraindications for inserting of intrauterine contraceptive devices? One, when there is pregnancy, when there is active genital tract infection, and when you are suspecting any gestational trophoblastic disease, and if there is any abortion, and if there is any endometrial carcinoma, cervical carcinoma, if there is any distortion of the cavity of the uterus, if she is a case of PID, which is acute PID, or if she has any pelvic tuberculosis. So all these are the absolute contraindications of intrauterine contraceptive devices. Then what's category 3, where risks overweigh the benefits? So in this, 48 hours to 4 weeks post delivery. Why? Because in this period, the chances of expulsion is very high, and benign trophoblastic disease and ovarian, because the chances of perforation is high, and whenever there is increased risk of STIs, and they have a increased risk, or they have increased sexual behavior, and if there is any HIV positive women, even they belong, and who are not on ART therapy. So they belong to category 3 because there is higher chance of infection. Next, coming to category where benefits outweigh the risks. So, in the nulliparous woman, especially if the age of the woman is less than 20 years, and if there is any trimester abortion, or if she has any valvular disease which is complicated, or any prolonged vaginal bleeding which is undiagnosed, and if she has any thalassemia, sickle cell anemia, iron deficiency anemia, all these, and if she has any STDs which are treated. So all these are category 2 where benefits outweigh the risks, and the safe category, that is category 1, is before 48 hours after delivery or after 4 weeks of delivery, or if she has any hypertension, smoking, diabetes, IHD, breastfeeding, stroke, thyroid disorders, migraine, post-abortal, especially in the first trimester, and hypertension. So all these comorbidities you can safely insert a intrauterine contraceptive. So whereas the OC pills can be contraindicated or relatively contraindicated whenever there are additional comorbidities, but such things do not apply for intrauterine contraceptive devices. So now let me explain the method of insertion. So firstly, I will explain you the method of insertion of copper T, and then we will go to the method of insertion of a LNG IUS. So firstly, we have to understand that this is a daycare or an OPD procedure. You need not even admit the patient, so you can just put or insert these devices on an OPD basis, and it just takes 10 minutes for insertion. So what we have to do, we have to ask the patient to void urine and cum, and then she has to lie down in dorsal position. We have to wear a sterile gloves and parts preparation by painting it with an aseptic solution like povidone iodine, and then draping the private parts, and then we introduce the Sims or Cusco speculum to visualize the cervix, and the cervix, the anterior lip is held with a valsella, and then a uterine sound has to be taken, and it has to be inserted into the cervix to measure the uterocervical length. So why uterine sound has to be inserted? One is to measure uterocervical length, and to see the position of the uterus, whether it's an anteverted uterus or it's a retroverted uterus. So that's how you will determine how the intrauterine device has to be placed. So once you have measured the uterocervical length, you have to take the copy. So if it is the copy 380A, or if it has the horizontal arms, we have to load the copy inside the applicator with the method called as no touch technique. So what do you mean by no touch technique? So we should not hold the copy either in the sterile gloves or not. Never touch the copy with your glove, sterile glove, or the bare hand. So with the property inside the sterile packet, you see whether the packet has not reached the expiry date, and the expiry is just for the packet and for the sterilization of the packet, and it does not apply to the property. So that is a very important take home message you have to take. So if the expiry is next month, the copy can be inserted with next month for the next 10 years. So it is not the expiry of the property, it's the expiry of the sterile packet. And the second important thing, you have to load the property. So what you will take the insert rod and put it into the applicator as it reaches the end of the vertical arm, and then the horizontal arm should be pitched and it should be inside the applicator rod. So this method is called as the loading of the property with the no touch technique, and the applicator is this, the property is loaded, and the inserted rod should be placed inside the applicator as it reaches the end of the vertical limb. And this loading technique might not be done for a properties like multi-load property. They are already in the form of U, and you need not load into the applicator. So you can directly insert into the uterus. So this is the difference between the property 380A or 250 or 375 and multi-load properties. So that is why multi-load properties are more preferred to these other properties. But the property 380A has the longest shelf life, that is 10 years. So once the property is loaded, we have to adjust so you take it out from the sterile pack and adjust the blue color flange based on the uterocervical length. So this flange should be at the level of the uterocervical length, and this has to sit at the level of the external os. So once the flange is adjusted, hold the lip of the cervix with valsalem and insert this copperty inside the uterus, and keep insert the rod steady and just withdraw the applicator. So when you withdraw the applicator, the copperty opens. So whenever it opens, it goes and sits snugly at the level of the fundus. So this method of insertion is called as a withdrawal technique, which is used for the copperty 380A. So once it sits snugly in the funds, then remove the applicator, uh, including insert rod. And once the threads are outside the external os, cut at least 2 to 3 centimeter from the external os and ask the patient to feel those threads. So after every menstrual cycle, she has to feel those threads. So if she reports of any missing threads or if she reports of a period of amenorrhea, she has to immediately seek medical help and we have to do a pregnancy test. So this is the procedure, and after we come, we have to remove the forceps, valsalem, everything, and then you can ask her to lie down for 5 to 10 minutes and then she can go home safely. So she does not require any analgesics or antibiotics or nothing is required because it is not such a painful procedure. It just takes 5 to 10 minutes of your time for inserting a copper, and we have to mention the date of insertion and the time period for this the property is uh, there for. So if it is a 3 years or a 5 years or a 10 years, and you have to ask her to replace or remove after that period of time. So this is about the copper T. Next, coming to the Mirena. So Mirena or the LNG-IUS, so this is in the form of T, and this will be having the uh, thread, and these will be placed inside the rod, and this rod will have something called as a slider. So this also will have a flange. So same thing, all the steps are same. Measure the uterocervical length and adjust that flange till that uterocervical length, and then insert the marina at least. Then firstly what you have to do, you have to push the slider so that the marina goes inside the applicator. So once you push the slider forwards, the marina will go inside the applicator, and then you insert it inside the uterus so that the flange is 1 centimeter away from the external os. Then once you've inserted the marina and the flange is 1 centimeter from the external os, that withdraw withdraw this slider to where it was before. So that withdrawal will cause the opening of the marina, and then you go and till you reach the resistance or till that flange is at the level of external loss. So that time the marina is at the level of the fundus, and then withdraw the slider completely backwards. So this will ensure that the marina is going and sitting at the level of fundus, and then you remove and cut the threads and ask the woman to feel for those threads. And this procedure for insertion of Mirena will be given in a information sheet which will be provided, and also will give the patient information sheet with date of insertion, that the advice on insertion and the doctor who is inserted. And we have to also ask them to mark for the bleeding or spotting, or if there is no menses, ask them to come after 1 month for follow-up, and also ask her to feel for the threads every month. And 90% of the times there is decrease in heavy menstrual bleeding, and 20 to 30 times of the time there might be amenorrhea, and 3 to 6 months there might be some amount of spotting or intramenstrual bleeding. It's completely normal. So this is the technique or insertion technique for Mirena. And next you have to understand what are the follow-up advice you will give. So you have to ask them to come back for follow-up after 1 month, and then you have to ask them to check the thread after every cycle. So after her menses stop, ask her to feel for the threads. So if she is not able to feel for the threads, she has to immediately come back. And what are the differentials for missed threads? So, and again, and very important follow-up advice is whenever she has any foul smelling discharge or pain abdomen or heavy bleeding or missed threads, or if she has any PID like features like dyspareunia, foul smelling vaginal discharge, acute pain abdomen, fever, all these she has to immediately report. Or if there is a period of amenorrhea and her pregnancy test is positive, she has to immediately report. So all these are the follow-up advice and you will counsel the woman accordingly and send her home. Next, coming to the missed threads. So how do you manage when there are missed threads? So if she comes to your OPD with missed threads, the first thing you will do is a specular examination. And sometimes the threads would have been rollen inside, it is still found at the external os. So if the threads are present at the external os, you will just reassure the woman. But if the threads are absent, then you will ask her to do a pelvic sonography. So in the pelvic sonography, the copper or the marina is inside, but the threads are not visible. You will still reassure the woman and you will tell the threads might have either been rolled above or they would have been fallen out. And if the threads are not there, but still the copperty or the marina is still safe inside the uterus, you can reassure her and send her home. The next thing, if even threads and if the copperty is not inside, then there are two possibilities. One, that it is expelled, and two, it is perforated. So, how do you confirm this? So you do a abdominal X-ray. So these properties are impregnated with barium sulfate that makes them radio opaque. So you do an abdominal X-ray, and if it is present or an abdominal X-ray, you can do a laparoscopic removal. But if it is not present on the abdominal X-ray, you conclude that it has been expelled and you can ask her for a reapplication of the copper T. So this is how you manage the missed thread. So it could either be rolled over or threads would have been cut off or the copper T would have been impregnated into the myometrium. So such times also you can remove it by doing a hysteroscope if the OPD removal is not feasible. And if the copperty is not seen on the pelvic ultrasound and it is not inside the uterus, we have to do an X-ray. And on X-ray, if it's visualized somewhere in the peritoneal cavity, do a laparoscopic removal. If it is not visualized on an X-ray, then you tell her that it is expelled and you can counsel her for reapplication. So all these are the management of missed threads. And removal is also a OPD procedure where we have to hold it at the level of the threads which are attached to the vertical limb, and you should not just hold the threads and pull because sometimes the threads might cut off. So take a straight artery forceps and hold it under vision, put the speculum, and then you hold at the level of the vertical limb and gently remove. And sometimes the vertical limb might come out, and some parts of property, if they're retained inside, you cannot manipulate in the OPD. You have to always do a hysteroscope removal, that's by direct visualization into the uterine cavity. Lastly, what are the side effects of intrauterine contraceptive device? So there might be painful menses or there might be slightly heavier menses in the next 3 to 6 months, or there might be some amount intermenstrual bleeding, or it might be some amount of heavy bleeding which is seen in the next 3 to 6 months. So this is completely normal and you have to reassure the woman, and you can put her on NSAIDs or you can put her on tranexamic acid and you can reassure her. And this pain abdomen, you can also treat it with mefenamic acid. And the bleeding is within the next 3 months. And then sometimes be excessive white discharge per vagina, that is leukorrhea, but you have to always differentiate whether it is excessive or whether it is abnormal. So if it is abnormal vaginal discharge, if it is associated with foul smelling, itching, it is copious in amount, or and it has other features of PID like dysmenorrhea or dyspareunia, all these are there, then you have to treat them with antibiotics. And next, the least possibility would be perforation of the uterus, which can occur in about 1.2 per thousand insertions. And sometimes there might be expulsion also, which is more common in the post placental intrauterine IUCD insertions. So what are the main side effects? The next few menses can be painful, they can be slightly heavy, there might be adjacent There might be leukorrhea, there might be infection, there might be perforation, and sometimes the failure rate is 0.5 per 100 women year. 1 in 200 might end up having a pregnancy. So if copper there at the level of os and the sac is there, it can be safely removed. But if property is located above the sac, please don't remove. That time you will be disturbing the sac and it might lead to abortion. So if the property is already in the cervical canal, it can be removed by ultrasound guidance. So always use a scan machine. So it's like a right hand to a logician. So we have to always use a scan and then you have to closely remove the property if it is located at the level of the cervix. But if it is in the fundus or if it is piercing the fundus or impregnated into myometrium or if it is above the gestational sac, please don't disturb the pregnancy. But if she wants to terminate the pregnancy, indication being failed contraception, we can terminate the pregnancy with medical methods and we can remove the property safely if it is visible or it might require hysteroscope removal. So these are all the side effects of copper and LNG IUS. So lastly, we will discuss about the advantages and disadvantages of a intrauterine contraceptive device. So what are the advantages? It's a long-term method. It can be done as a one-time motivation and regular supplies from the government, and we can get it freely from the government according to the National Family Planning Initiative. And there is no interference with sexual activity, and hormonal contraception can be used along with for as a part of contraception and for heavy menstrual bleeding. It is very effective. The failure rate is as less than 0.5 per 100 women year, and return to fertility is immediate, and there is no effect on breast milk. So it is safe in breastfeeding mothers, and it can be removed after 5 to 10 years depending upon the criteria, and it also prevents ectopic pregnancies in 50% of the cases, and there are no drug interactions. So these are the main advantages of a intrauterine contraceptive devices. So let's discuss what are the disadvantages. Firstly, training is required. So not all can insert a copy. So that is why training is very much important, and we have to motivate the woman during pregnancy and after childbirth for the birth spacing, and it requires intense motivation because some people have so many myths telling that the property will go into the brain, the heart, it will go and it will always cause uterine perforation, it is a cause of bleeding, it is a cause of infection. So it is myths which are followed. The woman will not be very ready to accept this method of contraception. So it requires us to create awareness about this and ask and tell them that this is the best method which is usually available as free in government settings and very at a very low cost price in the private settings. So, and the only disadvantage of this is it does not prevent the STIs or HIV infections. So these are the main important disadvantages when coming to intrauterine contraceptive devices. About intrauterine contraceptive devices. Hope you understood the generations of IUCDs. What is the MEC criteria? How do you counsel the woman for intrauterine contraceptive devices? And what is the timing of insertion? What is the method of insertion? And how do we follow? How do we insert? How do we remove? What are the side effects? And what are the main advantages and disadvantages? So this, according to me, is the best available contraception in our um, in developing countries like India, and it is also very cost effective. With this, I conclude my snapshot number 6, and for more videos on OBGYN, follow my channel, that is Gyne Wizard. Thank you.